Board President Doyle speaking. We now return to Thursday's edition of the Board Pharmacy meeting for June 13th at 10:30 a.m. We continue with rules review. We now will move on to package C1. That's Charlie C1, Division 115 Pharmacist, Staff Member Davis.
Staff Member Davis, as you said, discussion item C1. This is the board's first review of proposed rule language revision of the rules in the protocol compendia. So it's going to be an OAR 855-115-0345. The amendments propose to update the continuation of therapy protocol by adding early refills of non-controlled opioid use disorder medications pursuant to 2024 House Bill 4002, Sections 6, 7, and 9. It proposes amending the term vulvovaginal candidiasis in the current protocol to vaginal itching. It proposes adding new SARS-CoV-2 antiviral protocol pursuant to 2024 Senate Bill 1506. It is also proposed to amend the current version of the coronavirus 19 protocol. Today, the board will consider sending the proposed rules to the July rulemaking hearing and potentially adopt in August to be effective upon filing. So the first rule is first and only rule we're going to be discussing is 855-115-0345. And the first protocol we'll be discussing is continuation of therapy. It's mailing C1B. Great. I'm going to give a moment for staff member Melvin to get that up on the screen for the online participants.
C1A.
Oh, C1A.
Oh, I have first. Hold on. Anyway,
It's either C1A or
What's
C1B.
this one?
You have it up on the screen.
yeah, this is correct. Sorry. Disregard this.
Okay. All right, so in this modification of the protocol, the pharmacist may prescribe FDA approved in drugs and devices listed on the following compendium pursuant to the statewide drug management protocol. So 2024 House Bill 4002, Section 7 defines an early refill and provides limitations on the number and frequency of an early refill. Section 9 of the bill adds to the practice of pharmacy, ORS 689005, the prescribing and dispensing of early refills for medication for the treatment of opioid use disorder. Thus, the modification of the continuation of therapy protocol has been recommended to the board by the Public Health and Pharmacy Advisory Committee. They reviewed these amendments at their May meeting. So in major changes to the protocol on the cover page, under authority and purpose, a third bullet has been added under the authority and purpose related to the House Bill 2024, House Bill 4002. We won't have a statutory number probably for at least a year, so it's just going to be referred to as the House Bill. Addition of a section on an early refill of a non-controlled drug or device. Under the standardized patient assessment process elements, it modifies the provider facts, keeping the facts optional for insulin and non-insulin and non-opioid use disorder medications. Adds a requirement for early refills of opioid use disorder medications as required by the bill. It's in section 7, paren 3C of the bill that says notify the patient's primary care provider and the licensed healthcare provider who made the previous prescription of the pharmacist dispensing of early refills to the extent permitted by state and federal law. Under prescribing parameters, it clarifies in the first bullet that this is for non-opioid use disorder medications. So it just modifies the existing because there's different parameters for opioid use disorder medications. And it adds the third bullet that is specific to opioid use disorder medications, enacting limitations on early refills according to the bill. There were no other changes to this protocol package. I hand it back to you, Board President Doyle, for board discussion.
Member Doyle, thank you, Staff Member Davis. Discussion with Board Member Hall. Any questions or concerns?
Member Hall. Great. I think at this time I might have something
Board Member Beeman,
I think.
Board Member Doyle speaking. Would imagine that there was some conversation within the formulary committee about whether or not to include the early refills of opioid use in the same protocol as the continuation of emergency refills of insulin versus making it two separate things. Would you be able to summarize in a line or so the choice, that the reason that it was made to be combined?
Staff Member Davis, it was briefly discussed, I'm going off of recollection, it was briefly discussed the potentially separating this out. It would actually separate it out into 3 separate protocols. There would be your regular continuation of therapy for things other than insulin and opioid use disorder medications. And then you would have 2 additional protocols. I think a lot of people are protocol weary, and so agency staff had just put them all in one. The problem or the issue kind of becomes like every law has different restrictions, right? So now we have, like, for insulin, you can do this, and for non-insulin or for opioid use, you can do that. But then we already had an existing protocol that allowed people to do with different parameters. So we definitely can separate it out. It was a discussion, but we had not prepared that for the PFAC to consider. And I didn't give clear direction from the PFAC to bring it back as separate concepts, but the board always could request that, and we could bring that to the PFAC for their future consideration.
Thank you for that background. Member Chin,
Member Chin has no comments on this particular.
Joyce.
Board Member Joyce, so as the board, what kind of monitoring do we do? I mean, what requirements do, let's say, hospitals, SBD, that discharge medications under the opioid use disorder portion? Like, what records requirements are there any requirements monitor that this is what's happening? Do we have any kind of requirements for them to be able to, let's say, a hospital, that they're monitoring the dispenses lawfully and following the rule? Is there, unless a complaint is brought in, is that clear? I'm asking.
This is Board Member Chin. Hospitals don't do continuation therapy.
Right, but I mean, can't we discharge a patient?
Discharging a patient is different from continuation of therapy.
I guess
This is Board Member Chin, sir.
yeah, I mean, this was a question that was brought up to me, and I thought I would address it in this section, but I guess this is not the right section to address that. That's fine. I'll move on.
Board Member Doyle, I believe that there is a statute that requires dispensation of Narcan or something to that effect upon hospital discharge. And, but I find that not relevant to this package because this only deals with the early refills of a opioid use disorder, non-controlled substance item. So I see them as 2 different things.
Right, continuation of therapy as opposed to hospital discharge.
A hospital, under normal circumstances, unless they would use their retail drug outlet at a hospital site, would not be providing early refills of any of the opioid use disorder medication.
Okay, thank you.
Board Member Patel.
Member Patel, I just don't get it. Why so many protocols? Early refill opioid use disorder protocol, then emergency refill for insulin protocol, after protocols, more vaccination protocol, like pharmacists can confused. I mean, like I myself get confused, like there are so many protocols, like why can't pharmacists use their clinical judgment based on PDMP for the early refill opioid use disorder medication protocol? And why we even need a protocol? I just don't get it. It's like, is the medication we are giving early or in emergency is because that person has a disorder, which is which is going to be buprenorphine or Suboxone, and what are the consequences if we don't give, and what is the consequence if give like 2 or 3 days early? I am not, and I yet I have to see the survey of Oregon pharmacists that they love protocol. I think at some point we have to let them use their professional judgment. I'm just confused. I'm just stop there. I'm not agree with this more protocols. It is not. Thank you.
Member Hemmons,
Nothing to add.
Member DeBarmore,
Board Member DeBarmore. We have to stop this madness, but it is self-inflicted. It is not this body's doing. If you read the bill says the board shall adopt rules with all these things. So the statute, the bill that went through caused this. So that's where something has to change, is if pharmacists are going to be providers that can prescribe using clinical judgment, whatever, there has to be a change in how we are classified or what we are allowed to do. Having this list in statute and every single item coming through one by one, I agree with you. It is freaking madness. And no argument from me, but this is how it's coming through. It's coming through bills one by one. With the direction that the board must. And so that's the action that's being taken. The board must create, I mean, that's what the bill says. The board, the pharmacist must do an assessment. The pharmacist must. That's what it says in this, that's what it says in the statute. So it has to be changed at a higher level. We're just doing what we're being told to do by the legislature for this situation. And I do not disagree with you. So for those people sitting in the audience and on the phone who have the ability to influence what happens in the legislature, stop the freaking madness. Sorry, but no, this is what we have to do. It says what it's supposed to say.
Staff Member Davis has her hand raised.
I was just gonna read the part of the bill that Board Member DeBarmore is referring to. So in section 7, parent 6 says, in adopting rules to carry out this section, the board shall consult with the Public Health and Pharmacy Advisory Formulary Committee. We were required to take this to the committee, and thus you have a protocol.
Member Patel,
That did you refer to?
It's House Bill 4002. It doesn't have a statutory number yet, but it's section 7, parent 6 on page 9 of the final enrollment bill.
Yeah, I read the House Bill 4002. They just says, basically they say they want to create more access for the opioid use disorder patients. So they just say pharmacists must apply and obtain the DEA license so we can prescribe. That was my understanding. That's the legislative intent. If I'm the provider, they don't have to follow protocol for the early controlled substance refill or anything like that. You know what I mean? If you are a provider, then it's your judgment. And then you just say like, yes, you can have early refill for this controlled substance. If 4002, they also says the pharmacist, you are a provider and get your DA license, and then you can prescribe this controlled substance. And I don't think so that's their intent to create more protocol for early refill. I think their intent is prescribe controlled substance. That is my understanding.
Council Bertoni?
AAG Bertoni, I just wanted to echo with the staff member Davis read the portion of the act that required the consultation with the, I always want to call them fact, I know that's not what their name is, but the advisory formulating committee. There's actually a specific requirement of the board itself. The State Board of Pharmacy shall adopt rules to carry out this section. And that's section 7 of the bill, section 5. And the policy discussion about the volume of legislation is above my pay grade. But I did just want to echo that there was a mandate for this board to adopt section and the body that by statute creates programs.
Board Member Patel, no, I understand. And we should make a rule around it, but then I guess we decided that we are not going to make a rule because we cannot obtain the DEA license. I was like, so now I'm just confused that, okay, so what their intent is, what we shall do as a board, we are not doing that because X, Y, and Z reason. Then we are saying like we are going to create a protocol for early refill opioid, early opioid use disorder refill protocol. So, and that's what the PFAC committee wants. They want the protocol for early refill.
Board Member Doyle, the board has been charged with creating something to effectuate the intent of the bill. And to me, it seems part and parcel with what has been requested of the board is aligned with the formulary committee's work. The formulary committee is bringing us their best suggestion on how to operationalize this. And then we as a board can approve it or not, send it back to a formulary committee, or potentially choose to operationalize it in a different style of rule. Member Hall? I've lost my track. Has everybody had an opportunity to speak at least once? Are the board, the floor is open for any additional comments? Staff Member Davis, we talked about package C1, package C1B.
This was C1A.
Additional comments in the other areas?
Staff Member Davis, on your agenda, it's incorrectly numbered. It's C1A for the continuation of therapy. And now we need to move to C1B.
Yeah.
Okay, thank you.
Which is actually
VVC.
vulvovaginal candidiasis.
Great.
Give us a minute for staff member Melvin to pull this protocol up. So the only change to this protocol was changing the phrase vulvovaginal candidiasis to vaginal itching. This change was proposed based on previous board and PFAC conversations to make clear that this protocol does not permit the pharmacist to diagnose vulvovaginal candidiasis, but to prescribe medications for symptom management of vaginal itching. At the PFAX meeting on May 8th, 2024, they made a motion to recommend the vaginal itching statewide drug therapy management protocol version 5.2024, which is what you're seeing today, as they revised during the meeting to the board for review and was unanimously carried. However, after the meeting, one committee member emailed the board with the following. I am concerned with the protocol for what is now vaginal itching. While I appreciate that the self-screening intake form is supposed to accomplish, I would never recommend my providers to just prescribe fluconazole orally for vaginal itching. The number of times I've had a patient tell me they had another yeast infection, and yet it is either bacterial vaginosis or atrophic vaginitis is numerous. So I would maintain that getting an actual diagnosis is important. Additionally, I apologize for not catching this moment during the moment, but I was busy processing the bigger question. As I reread the protocol on the pathway for vaginal itching, item 4 has a statement that is now false. The statement is, all therapies are equally effective in treating uncomplicated vaginal itching. This is not a true statement. Changing vulvovaginal candidiasis to vaginal itching completely changes the meaning of the sentence. They are not interchangeable, which also takes us back to my previous concern. Agency staff have not encountered this situation before, where a committee member who motioned in favor of a protocol had later insight and concerns about the protocol. So I've asked AAG Bertoni to talk with the board about your options.
Your options are limited by the statute that set up and established the advisory committee. Under that statute, obviously, if you, yes, they establish protocols and provide them to you. Your options are, and no disrespect to your options are to accept the protocol or to send it back to them with instruction to revisit it, review it, in light of the feedback from this one board committee member. The board really doesn't have the option to modify the recommendation that you've received from the advisory committee. You can adopt it, or you can kick it back to them, but modifying it is not really have that authority. Happy to answer questions.
Are there any questions from the board?
Board, sorry,
Member Evans, please.
board member Hammond, so are you saying that the only choice that the board has is to accept what has been put forward by the committee, or to send it back to them and then they can make changes?
AAG Bertoni, yes, that's what I'm saying. And I'm just for the record, I'm looking at ORS 689, 649, sub 7. This is the statute that creates the committee, the advisory committee. And it says the committee shall recommend to the State Board of Pharmacy for adoption by rule of the board a formulary of drugs and devices that a pharmacist may prescribe and dispense. This is the protocols that we're talking about. So the committee has authority to recommend, and the board has authority to adopt the recommendation by rule. The statutes, the statutes don't seem to allow the board to modify the committee's recommendation.
Yes, board member Hammond, so we don't have the authority to modify their recommendation, but we can make our own, can't we? Can we make our own suggested changes?
The AAG Bertoni, so you're talking about making your suggested changes to the protocol.
Right, yes.
As I read the statute, the advisory committee has to make changes to the protocols. And it's possible if this board could have developed, and I haven't looked at this, but do your own independent rulemaking within OAR and create rules around this treatment area for vaginal itching. A simpler solution might be to kick it back to the committee and say, we received this feedback from one of the committee members who's got an MD and it's some basis for raising the concerns that he's raised, and ask them to give you, in light of his concerns, a revised recommendation so they can revisit it and make the best information.
Other questions or comments from board member Chin?
Board member Chin, thanks Dr. Mark Myers for his letter. Just to provide some additional information to board members who might not be prescribers of this treatment. And up to date, differential for vaginal itching is huge.
and just wrote down what it says, although vulvar pruritus is a cardinal symptom of Candida, less than 50% of women with genital pruritus have vulvovaginitis candidiasis. There's a huge list of differentials for that symptom, which you don't probably want to know all of them. And then there's with the bacterial vaginosis that Dr. Myers mentioned, 20 to 30% of women will have a co-infection with the Candida. And up-to-date basic patient information on this lists common causes, which it is only one. But the first recommendation is that the patient see a nurse or a quote doctor for an exam. And so I highly recommend that we do not adopt vaginal itching as the same as treating vulval candidiasis.
Other comments, board member Adams?
Board Member Hemmings, why did we change it in the first place?
Board Member Chin, this is you. Yes.
Okay.
At one of your very first meetings, you noted that how does one diagnose, because we were talking about diagnosis of different things. How did we get vulval vaginitis on here? How is that? How does a pharmacist diagnose that? It was because you picked it up, my dear. Very astutely. And even the providers on the PFAC. So I was on the PFAC when we did this. This is still board member Chen. And this was early on in our inception of doing these protocols. And so we were really focused on how to safely expand the scope of pharmacy to allow for access to care. That's the big goal. About think this one without really thinking through, because as providers, we treat vulval candidiasis left and right, but we also think through all the differentials, and I don't think that we thought through every single different, the whole process of this, but it is, you can't change a diagnosis to a symptom and have it be the same thing.
Remember Hemmings, I was just curious. I'm not saying we shouldn't have. I agree with what the doctor is saying. I mean, I would agree that we shouldn't adopt it, but I was just curious what that might be.
Other comments or questions with regard to the VVC package C1B? Staff member Davis, if I may suggest that we continue with the other C1 sub packages and then based off of, and then at the end, go back to C1 and see what type of edits might be necessary to C1 rules themselves.
Staff member Davis, staff member Melvin is pulling up a slide that I used during the PFAC meeting for the next discussion, which is going to be mailing C1C for the SARS-CoV-2 antiviral. We've had a long history with this over the last few years, and so I'd created a slide that kind of summarized where we've been, because we've been here before, and I thought, some of you would be like, what is going on? So back in December of 2021, the FDA issued the emergency use authorization for Paxlovid. In 10/2022, we temporarily adopted a COVID-19 antiviral protocol, which permitted pharmacists to prescribe Paxlovid. And then we also sent to rulemaking the permanent adoption of that protocol effective 2/1/2023. Then on 2/1/2023, the FDA revises the EUA to Paxlovid to now require a diagnosis to prescribe. Previously, it had just been a positive test. There was no diagnosis requirement, then they changed diagnosis. So then we come to the board meeting the next week and we temporarily repeal this COVID-19 antiviral protocol. Then we permanently repeal it, because that's what we do, doing both. And then on 3/8/2024, now the EUA is completely gone. Like the EUA labeled Paxlovid is no longer authorized, it's not being dispensed out of any pharmacy. And then also, effective in March 2024, we had 2024 Senate Bill 1506. It was signed into law. It became effective 6/6/2024 and operative on 10/1/2024, meaning the board can take action on it now. And we just need to make sure it's effective and operative by 10/1/2024. And then the bill itself has a sunset clause on it. It will be repealed June 30th, 2026, with the intent that they are going to come back and revisit the language of this bill about test to treat. So it had initially started as not a very large bill, but it had 5 or 6 items a pharmacist could test or treat. And then through the process, it got whittled down to just this one to permit pharmacists to continue to be able to prescribe Paxlovid after the PrEP Act expires later this year. So we have this bill. The bill's kind of like a temporary bill, if you think about it. And then the expectation is either it will be completely repealed or that it will come back with a new version with maybe more things that a pharmacist could test to treat. We'll just have to see how the legislative session hashes out. But I wanted to kind of give you that walk down memory lane, because yes, what's old is new, what's new is old. You're seeing something you've kind of seen before. Because there was a protocol previously, the highlights on the document represent the sections of changes from the old protocol to the new protocol. So I'm just going to go over like the big picture of like what changed. On the cover page for the pharmacist training education, as staff member Melvin pulls this up, you scroll down under pharmacist training and education. It used to say is familiar with. Now it just they changed it to must be familiar with how to access patient laboratory data and assess renal and hepatic function. And then they also updated the list of potential training programs. The ones that were listed were from very early on after the product had come out. We've learned a lot about the product, and so these are other programs. They're not required, they're just recommended, and they're just some suggestions to make it easy for the pharmacist to maybe find some additional education. On the patient intake form, the previous number 1 was removed, as 2024 Senate Bill 1506 requires the pharmacist to test for SARS-CoV-2 and prescribe. And the old protocol had permitted the patient to bring in a home test that could be used for prescribing. So that question was removed about, did you have a positive home test? Please indicate the date that you took it. They removed from 2P, there used to have overweight/obese, as overweight is suggestive of higher risk, but is not considered an actual risk factor. They also removed sickle cell from the list for the same reason. And they removed thalassemia from the list as it has mixed evidence as to whether it be a risk factor. So they just left on here what are like true risk factors that are not just suggestive. And then in the section to be completed by the pharmacist at the bottom, keep going. They added number 1 to the document about the pertinent lab info, because now the pharmacist or the person that they have had to administer the test, and I'll talk a little bit more about that later, you need to record that information. Remove the reference to overweight in number 2, and remove the reference to giving the patient the EUA fact sheet, as the EUA product is no longer authorized by the EUA. Thus, you don't need to give the EUA fact sheet. On the assessment and treatment care pathway, for number 1A, changed from 12 years to 18 years. Paxlovid is only authorized for 18 and over. The old 1B was removed. It talked about a weight less than 88 pounds. Number 2 was updated language permitting all types of SARS-CoV-2 molecular or antigen test. Per the Senate Bill 1506, a pharmacist may delegate to an intern, COPT or PT, the administrative and technical task of performing the test. So there's a note there just to remind the pharmacist that they can use their other personnel to do these types of tasks. In number 3, they updated the note to be only about obesity and removing the language around overweight. In 3B, they modified the note for clarity. And at the end of each section, you'll kind of see this language throughout. It says the modified language Paxlovid is not indicated under this protocol. So there are, that's what these protocols are all about. Like you follow the protocol pathway. And then if you run into something that the patient no longer is eligible for the protocol, then they get referred out. So this is one of those steps. Like if, yes to either A, B, or C, proceed to step 4. Otherwise, it's not indicated in the protocol, so you don't continue down the protocol pathway. 4, 5, 6, and 7 just have that same language about Paxlovid not indicated under the protocol. Number 7, they removed the specific list of drug interaction tools. Paxlovid is no longer this like new thing we have. It's all in all the drug databases. And so a pharmacist can use whatever drug interaction tool they choose to use as they would normally use. And then in 8, they removed documenting patient education that was required by the EUA. Again, there's no EUA anymore. Pharmacist prescribing would still be required to counsel on the product according to our counseling rule in 855-115-0145. So it's no longer like a necessary step. So you don't see a section about that. And then in 9, they removed the requirement to report the adverse reaction and medication errors using the FDA 43500, and that was only for the EUA product. That was specific to that. So now your new 9 is just notifying the primary care provider. On the prescription template, we just removed and have been removing for protocols. There was a verified date of birth with valid photo ID right at the top. We got rid of that. And then finally on the provider facts, removed the patient provided with an EUA fact sheet, removed informational self-isolation as the CDC recommendations have changed. The pharmacist can include in their standard counseling. That information. We removed the contacting Pfizer medical information, the NIH treatment guidelines, and the EUA fact sheet. There was like all this information about where you can get more information. Now at this point, Paxlovid is pretty commonplace. And added a standard statement we've been putting at the bottom of the protocols about the authority to issue the prescription. So with that, I will hand it back to Board President Doyle for any discussion on this protocol.
Member Doyle, thank you. We're discussing the SARS-CoV antiviral package, C1C. We begin with Board Member Beeman. Any questions, concerns with what we've been presented by the formulary committee?
Question for that.
Board Member Doyle, no questions. Board Member Chin.
Just a curiosity. When you have in background information too, when one of my peeps would come in and check off maybe 6 or 7 of these things as yes, but they still qualify for Paxlovid. Does that mean that the pharmacist is going to go through, obviously you have to go through each of those. What is the, I'm just not sure about what the concern is like with dementia and Paxlovid or having, I was curious list is all I was thinking.
Staff Member Davis, from the original rendition of this protocol, I'm thinking back, the subject matter experts had created this list based on the CDC's list for high risk patients at high risk to develop COVID-19. So it's just taken from the
So
CDC.
these are the people who really should have it rather than.
Yeah, it's not eliminating them. It's saying, yeah, for sure, you should.
Okay, got it. Well, double check, double check. Yes. Okay, got it. Thank you.
Joyce.
Whoever enjoys, no concerns.
Member Patel.
No comments.
Member Hemmons.
No comments.
Member DeBarmore.
Nothing that.
Member Hall.
Yeah,
You. Move to package C1 Delta coronavirus 2019.
Okay, Staff Member Davis, Staff Member Munlit's pulling it up. This is the protocol. You are just gonna see every board meeting. I anticipate we're gonna see it again. I also anticipate that there will be a change midsummer that will necessitate some additional meeting of the board. Because ACIP meets the last week of June, and it is likely they will make the recommendation for the fall series with COVID. So we will be seeing this again. But the subject matter experts on this protocol just did like a wholesale revision. So you may remember, maybe not. The last revision they had to make because there was the new recommendation for patients over age 65 to get an additional dose of the 2023-2024 formulation. And it kind of just messed up everything in terms of it made it really hard to read the protocol because they didn't have it in charts. So they've gone back and redone it in a chart format to be more similar to the other. So I'm going to point out like the therapeutic type things that have changed, but not that we just moved information from a written list to a chart sort of information. So throughout the protocol, they changed the words Pfizer to Pfizer-BioNTech. They updated persons to the word individual, so it was consistent throughout the protocol. And they changed UG for microgram to MCG just to be consistent because it was used either way throughout the protocol. In 1A, they show the new recommendation for that additional dose of the 2023-2024 and 65 and older. They reworded 2A to be clear that a pharmacist must follow the protocol and not administer according to the ACIP recommendation or the vaccine package insert. That language had confused some pharmacists out in the field. In 3, all schedules were updated to a table format that was copied from the CDC, very similar to what you'd see on the CDC's website. Also in 3, COVID-19 vaccine doses in the initial series should be homologous. They just made that clear. Like it's just for your initial series, you shouldn't be switching manufacturers. You should stay with one manufacturer. In section A for immunocompetent, the table about immunocompetent is 3(1)B. Clarification on completing the series when a child transitions to age 4 to 5 during that initial series. And in 1C, info on the transition from ages 11 to 12 during the initial series. And you'll see that kind of throughout the protocols. Section B on immunocompromising conditions. In 2A, they added an additional dose of the 2023-2024 formula. And then clarified that any further doses by prescription are issued by a healthcare provider. 2B has the same info as 2A and 1B about the age transitions, and 2C as well. Section 7, under precautions, they added the development of myocarditis or pericarditis to be consistent with the product labeling. And in section 10, under storage and handling, they added clarification that the glass syringe presentation of the Pfizer product expires as indicated on the packaging. The current/previous, what would be previous protocol says within 6 months. So they wanted to make that technical fix that they identified after the fact. Do any board, back to you, President Doyle, for board discussion.
With regard to the coronavirus 2019 package, begin this round, I do not have any questions. Board Member Chin,
No questions.
Member Joyce, question, Board Member Patel,
No comment.
Board Member Hemmons,
Questions?
Member DeBarmore,
Nothing to add.
Member Beeman, Board Member Hall,
I have nothing.
Member Beeman.
Comments?
So Staff Member Davis, it appears as if there's concern with regarding package C1B BBC, and so the board may contemplate changes to actual rules as presented in C1.
Staff Member Davis, Staff Member Melvin has pulled up that mailing. Is going to make So paren one would stay the same, paren one or two B, it sounds like possibly the board has made a decision to send that back to the formulary committee. I'm not sure. So, but if you do that, then that would be removed. That would no longer be modified. Paren two D will stay the same.
To be.
And then the last one is, can't see it, the vaccine protocol under,
Coronavirus.
yeah, line 64.
Board Member Doyle. So with regard to the BBC, I think that there's probably board interest in sending this back to the committee. My question revolves around leaving the EVC in the original language here, and whether or not we need to, as we have in the past, I understand with COVID or whatever, we've temporarily we've temporarily suspended a protocol, and I'm wondering if that would be appropriate action to take it this time. Otherwise, the BBC protocol has been available for, I'm guessing, at least a couple of years, 4 years. There are concerns about limiting access and or prescription coverages from insurers if they potentially have to buy the product over the counter as opposed to getting it prescribed by a pharmacist. So is it within the from a mechanistic standpoint of actions that we can take today, it's within the purview of the board to potentially suspend or mod, I guess. I don't know if that would be through modification of language on line 29 or how we would otherwise do that. Council Bertoni.
So AAG Bertoni, I think what you would do, and staff member Davis will throw her hands up if she thinks I've got it wrong, is you would adopt the rule changes, but not the change shown for 2 sub B. This would not adopt that rule change, and you'd send them out, you would essentially reject the proposed protocol that's come to you from the advisory committee, and then ask the advisory committee, you don't have to vote on this, but we're hearing direction to the advisory committee to go back and revisit this in light of the concerns that Dr. Myers raised, and maybe to listen to the audio of the board's discussion on this topic today, so they can kind of come back to you with a better informed or maybe fuller protocol recommendation. Anyone on staff feel like we should say something else?
Staff member Davis, I think Board President Doyle was alluding to potentially doing a temporary rule to immediately suspend, like to immediately get rid of this protocol, and then filing for the permanent rule to repeal it. But I might have misunderstood. Like, we can't modify the protocol, but do they have the power just to repeal it?
To repeal the existing?
Correct.
In a temporary.
Look, Board Member Doyle, in the current one, I mean, the point of changing VVC to itching was to get away from the diagnosis issue. And because we've repealed, or we've at one time there was a proposed protocol for shingles, and we did not move forward with that because ultimately it would require a pharmacist to make a diagnosis that rash was consistent with shingles presentation. And so now, if there's a diagnosis that's required for BVC, hence the necessary change to the protocol, including itching as opposed to making that diagnosis, is it the best intent for the board to temporarily suspend the VVC protocol out of weighing the interests of protection of the public versus access to the medicine versus potential liability for the board and or the pharmacist performing or following the protocol.
So this is Council Bertoni. We've asked an enormous set of interesting policy questions. One was what's in the best public interest? What creates liability for the board? What would create liability for, if I understood that you're concerned about what would happen for pharmacists and what would happen in terms of access.
Not necessarily asking for an answer, but those are the things that are circulating into my head. And those are things that we have thought about in the past when, for example, not to push forward a shingles treatment plan.
So it is Council Bertoni, you could engage in temporary rulemaking today, but you'd have to find that the temporary rulemaking to suspend the current protocol. But you'd have to find that failing to act promptly will result in serious prejudice to the public interest. But you had the existing protocol in place for some time without evidence of a serious harm to the public interest. So it might be difficult to justify a temporary rulemaking which didn't allow public notice and comment in advance to suspend it, given that it's been in place and apparently, as far as we know, is functioning adequately, even if there are reasons to revisit it. So I would not encourage you to do that, at least today. I would not encourage temporary rulemaking unless you really feel you can make those findings. And I'm not sure exactly how you would do that given the history. But you can certainly ask the committee to go back and do a deeper dive and come back to you with a more careful recommendation.
Board Member Chin?
This is Board Member Chen. In light of that, I can understand why we wouldn't take that out, but if the PFAC is not able to
Deliver a revised
Right.
protocol that is acceptable to the board.
that is acceptable to our rules and statutes, would they then recommend that we remove this and that's how we do it? And it doesn't need to go to rule, it's just,
Member Doyle, they would make the recommendation to rescind the protocol that would change the rule here. We would then send that to rulemaking hearing at a later time, and then it would be removed and not available.
to see how the whole picture goes. Thank you.
Any other questions or comments? Staff member Davis has made a correction or a change to line 29, para B, which leaves intact the old language for VVC, the protocol, since June of 2021. Are there any further comments or questions regarding this particular line only?
Member Hennon, so we took out vaginal itch.
Member DeBarmore, we didn't recommend.
Board Member Doyle, we haven't taken a vote on it, but it appears as if the board is in concurrence with the concerns that Dr. Myers of the PFAC had brought forward in his external communication to the Board of Pharmacy, and that by changing a VVC quote unquote diagnosis to VVC itching, it changes many different aspects of appropriate treatment. And in his opinion, it's not written as itching, it's no longer a valid pathway for a practitioner to follow.
Rams, I got that. I was just trying to understand why it was there in the first place. Why did it say vaginal itching in the first place if we hadn't already agreed to it?
Was Board Member Doyle, that was the proposed change.
Okay.
Yeah. And so now for clarity, we're removing the editing of the proposed change to just leave the original language, which would leave intact the VVC protocol as we've known it for the last 4 years.
requires diagnosing. Okay, got it.
Staff Member Melvin.
Staff Member Melvin, before you motion, in this case, since we've done this work, would be as revised. Thank you.
Are there any other questions? So
So board member Hennis, would we be then voting on as revised and another vote to send it back to the committee for review? So two different votes, correct?
Member Doyle, my understanding is that because we are not accepting the change to BBC itching, then it's board direction, then BBC itching is not approved, and we're otherwise providing board direction for staff to take this back to the formulary committee for further workup. Pause for a moment.
Thank you. So. Because I don't remember sending it back. So like to do all the protocol. Did you vote to ask them to go on vote? No. That's what on this here. Okay, so. When it comes to the, when you can start something with this legislation. Progress is a concept. I don't know how to do votes. So do you want me to compose? Yeah.
Yes.
Over Tony.
AG Bertoni, we aren't 100% sure if you need to do a vote or not, to refer it back. And we recommend that you do just for a sort of, record and to provide instruction to the advisory committee. And I'm happy to compose that vote on the fly when we're ready for it.
Staff Member, do you want to start with your first motion and then that could be a second?
Board Member Doyle, on the screen that you see in the room before you, it is the protocol compendium package C1, whereby there have been some additions on line 16, which add early refills of opioid use disorder medications. We've revised line 29 to not make any changes to the BBC protocol. And on line 33, we've added the SARS-CoV-2 antiviral. And we have updated the date on line 64 of the coronavirus 19 package. And therefore, if this is approved, that would carry with it the coronavirus package, the continuation, the therapy package, and the SARS-CoV-2 package, but not the vaginal itching package. There are a motion to move to send proposed rule OAR 855-115-0345 as revised to the July 23, 2024 rulemaking hearing.
Member Chin, moves.
Is there a second?
Give the former revised.
Motion has been moved and seconded. Now I'll call roll vote to send proposed rule OAR 855-115-0345 as revised to the July 23, 2024 rulemaking hearing. Board President Doyle, yes. Board Vice President Chin.
Yes.
Board Member Beeman.
Yes.
Board Member DeBarmore.
Yes.
Board Member Hall.
Yes.
Board Member Hemmons.
Yes.
Member Joyce.
Yes.
Board Member Patel.
Abstain.
Motion passes with Board Member Patel abstained. We'll now formally move to take a vote to send the BBC vaginal itching package proposal back to the formulary committee. I asked for Council Bertoni for advice on.
So motion language might include a motion to refer the BBC protocol, the proposed amended changes to the BBC protocol back to the formulary advisory committee with the request that the committee review the protocol and provide any recommendation it has to the board in light of the questions raised by the committee member and in reference to today's discussion by the board about the BBC protocol. You're referring it back and you're asking them for a recommendation. They may or may not give you one, but you've asked them to review both Dr. Meyer's concerns and the discussions of the board meeting.
Board Member Doyle speaking. Is there a motion to move to send the BBC vaginal itching package with its proposed amendments to the board back to the formulary committee for review and rewrite, inclusive of the comments received by formulary committee member, as well as conversation from the board members today?
Member Chin, so moved.
And then Board Member Joyce?
Motion has been moved by Board Member Chin, seconded by Joyce. I will now call roll. Board President Doyle, yes. Board Vice President Chin,
Yes.
Board Member Beeman, Board Member DeBarmore, Board Member Hall,
Yes.
Board Member Hemmons,
Yes.
Board Member Joyce,
Yes.
Board Member Patel.
Yes.
Motion passes. Staff Member Melvin, there had been a minor modification back on the previous package, C as in Charlie, 855-139-0200, where we had added a couple of words. Is it necessary for me to go back and remotion that with the words as amended?
Did we revise it? Wait. Sorry, staff member Rowan, give me just a moment. I need to look at it.
I'm just double checking. We only admitted quote unquote line 2 or line 10, which was para 2. There was no new language in it. It was just removing line 10.
Right, this was.
Yeah.
Yeah, what we did. Oh, we removed, yeah. So it wouldn't be as revised.
There were
Yeah.
options of like 2-1, 2-2, and since we deleted those, did we?
Staff member Melvin, so I don't believe it's as revised because repealing all of 2 was a suggestion.
Right.
And you can correct me if I'm wrong, but, okay, thank you.
Completed discussion on package C1. And we'll now move to package C2 for Division 135. Staff Member Davis.
Staff Member Davis, this is discussion item C2. The board is conducting its first review of a proposed rule amendment to modify the definition of accredited program to include programs accredited by the American Association of Veterinary State Boards Registry of Approved Continuing Education as a medical program, and to permit licensees to utilize a limited amount of credits earned through this accreditation body for required CPE. The board discussed this at the last board meeting and directed staff to bring back a proposed rule change. At today's meeting, the board will consider sending the permanent rule amendment to the July 2024 rulemaking hearing and potentially adopt in August 2024 to be permanently effective upon filing. So the first rule change is in 855-135-0001. And that's for the definition of an accredited program, adding parentheses. So it was reorganizing these because they weren't previously bulleted and it become a very long run-on sentence. So you're gonna have parent A, parent B, and then parent C, which adds that continuing veterinary medical education accredited by, I'm just gonna say AAVSB as a medical program to the definition of accredited program. As a reminder, in veterinary medicine, this AAVSB maintains a registry of approved continuing education. That's the RACE acronym. and standards for approved providers of AAVSB race accredited programs. So similar to ACPE or ACCME, Category 1 accredited programs for human medicine, race medical programs are reviewed by a committee of veterinary professionals and require learning objectives, qualified instructors, and post-course assessments. I'm just going to go through the other change and then bring it back to you for discussion. In 855-135-0010, line 71 on the mailing. During the board's discussion in April, these proposed rules to permit a pharmacist to earn up to 10 hours of CPE for each renewal, and technicians earn up to 6 hours for each renewal from one of these race medical programs. This is similar to the allowance for ACCME, AMA Category 1 accredited programs. So in paren 2E on line 996, it says time spent and the following activities may be included in the calculation of CPE credit: an ACCME, AMA Category 1 accredited program, or an AAVSB race approved medical program, up to the following limits per renewal cycle: 10 hours of CPE for pharmacists and 6 hours of CPE for certified organ pharmacy technicians and pharmacy technicians. Hand it back to you, Board President Doyle, for board discussion.
Board Member Doyle, thank you, Staff Member Davis. Conversation or regarding the proposed rule changes for Division 135. We begin Board Member Finn.
Comments?
Member Joyce.
Board Member Joyce, no comment.
Member Patel.
Comments?
Member Evans.
No comment.
Member DeBarmore. Member Hall.
Comment?
Member Heaton.
Comment.
Board Member Doyle. I believe that the rule changes that are being proposed here are congruent with the direction of the board during its discussion at the May meeting. So I'm in agreement with them. Is there a motion to send proposed rule OAR 855-135-0001 and OAR 855-135-0010 to the July 23, 2024 rulemaking hearing? For a second?
Second Board Member Chen.
Moved by Beeman, seconded by Chin, and I'll call roll to approve to send proposed rule OAR 855-135-0001 and OAR 855-135-0010 to the July 23, 2024 rulemaking hearing. Board President Doyle, yes. Board Vice President Chin.
Yes.
Board Member Beeman. Board Member DeBarmore.
Yes.
Board Member Hall.
Yes.
Member Hemmons.
Yes.
Board Member Joyce.
Yes.
Board Member Patel.
Yes.
And passes.
All right, Staff Member Davis. This is now going to be mailing.
Well, what you're gonna show first.
No, but it's gonna be C3 is what we'll be talking about. She's gonna pull up a slide just as a reminder. I'm gonna talk to you. So the board's gonna continue its first review of this set of rules. We're going to finish this today. I have full faith that we can get there. There's just 2 rules left. As a reminder, this is part of our previous strategic plan 2022 to 2024 to update the compounding rules. So we're just trying to finish up this work. We did have a work group develop and help revise these rules. As a reminder, the work group is a public body and subject to public meetings laws. The work group members represent the interest of persons or entities likely to be affected by the rule, and the work group members provide advice and insight on the specific topic and any proposed rules related to that topic to the board. The work group's role is advisory only. Based on input for the work group and using the lens of patient safety, agency staff drafted rules and modifications to the proposed rules. You may recall the board did not discuss the rules a year ago in June 2023, but did send them to rulemaking to get some public comment. And then further modifications were made to the rules based on that public comment. The rule language you see in yellow on this draft denotes agency staff proposed amendments that were made between the rule package going to rulemaking. And then with, in the August 2023 board meeting, I've had made no updates to this package since then. So there's some things that when you get this the next time for the full second review, there will be some modifications because some of the rule language has changed in the meantime. So we're gonna pick up where we left off, at the last meeting, which is going to be OAR 855-183-0710. But before we go into that discussion, I did just want to remind you, this was the compounding presentation that we had at the August 2023 board meeting, and slide 10. Because the two rules we're going to be discussing today, one of them at least, is about this, and I just want to remind everyone about this topic. So the Compounding Quality Act, which is a federal law, separates pharmacies into, compounding facilities into either 503As, which are our traditional pharmacies, what you think of, when you think of, all the different local pharmacies in the state. And then you have 503B, which are outsourcing facilities. The 503As are registered with our state, they're inspected by our board, and they can be inspected by the FDA, and that does happen. They have to do patient-specific compounding, which is going to be important to the conversation that we're about to have. They have unique needs and they can do personalized dosage forms. They have to have patient-specific labeling and they have to comply with USP standards. Whereas an outsourcing facility has to register with the state and the FDA. They can be inspected by us and the FDA, or are inspected, but I don't think we have any outsourcing facilities in Oregon right now. Getting a head nod, still none in the state of Oregon. They're large scale compounders. They produce standardized medication in bulk for providers and hospitals, standardized labeling. They have to comply with CGMP, current good manufacturing practices. They have to report their product lists to the FDA biannually, and they have to report adverse events to MedWatch. So they just have a really different, the main thing you need to really think about is they're not patient specific compounding. A local pharmacy can only do patient specific compounding. That's to be pertinent to the discussion we're about to have. So 0710, I don't know where it is in the mailing. Rachel's gonna change billings. And it's gonna be really far down, and I didn't look up a line number, so just go to the end and then go backwards is probably your fastest way to get there. Oh, maybe not, because we have all the repeat. Sorry.
Right.
We're close.
7:30,
It's this one.
7:10.
All right. So 855-183-0710. Agency staff initially proposed adding rules regarding compounding of essentially a copy of a commercially available drug because the board receives regular questions regarding this practice. In addition, USP does not address it. In section 503A, which I just went over from the FD&C Act by the Food and Drug Administration Modernization Act and amended by the Drug Quality and Security Act, describes conditions that must be satisfied for human drug products compounded by a licensed pharmacist in a state licensed pharmacy or federal facility or by a licensed physician to qualify for exemptions from 3 sections of the Act. Section 501 concerning, or 2A, 2B, and this is about having to comply with good manufacturing practice requirements. So CGMPs, so 503As are exempted from having to comply with CGMPs. In section 502 F1, this is about the labeling of drugs for adequate use. And section 505 concerning the approval of drugs under new drug applications or abbreviated drug applications. To qualify for exemptions under section 503A of the Act, a drug product must be compounded by a licensed pharmacist or physician who does not compound regularly or in inordinate amounts any drug products that are essentially copies of commercially available drug product, among other conditions. The FDA states in its compounded drug products that are essentially copies of a commercially available drug product under section 503A of the Federal Food, Drug, and Cosmetic Act, guidance for industry. So they have an official guidance document was published in January 2018. that the compounding of copies of an approved drug would create significant public health risks because patients would be unnecessarily exposed to drug products that have not been shown to be safe and effective and that may have been prepared under substandard manufacturing conditions. The FDA has investigated serious adverse events in patients who receive contaminated compounded drugs when a comparable approved drug made in a facility who is subject to CGMP requirements was available. Per the FDA guidance, the FDA intends to consider a compounded drug product to be essentially a copy of a commercial drug product if the compounded drug product has the same active pharmaceutical ingredient or API as the commercially available drug. The API has the same, similar, or easily substitutable dosage strength and is commercially available drug product that can be used by the same route of administration as prescribed for the compounded drug. So with this framework, agency staff drafted these rules. A drug outlet pharmacy, DIPTO, correctional facility, CF or CHC, or outsourcing facility may only compound a drug preparation that is essentially a copy of an FDA-approved drug if, one, the compounded preparation is changed to produce for an individual patient a clinically significant difference to meet the medical need as determined and authorized by the prescriber. The relevant change and significant clinical difference produced for the patient must be indicated on the prescription. Paren 2, the FDA-approved drug is identified as currently in shortage on A, FDA drug shortages database published on the FDA website, or B, American Society of Health System Pharmacists, ASHP shortages database published on the ASHP website. The work group did discuss possible regional shortage issues as those federal lists are notoriously behind or outdated and do not reflect drug availability in some areas. The federal lists do not reflect all shortages that impact patient care and are not a good source for veterinary drugs. A good example of this was the current shortage at the time of buprenorphine. We're still having some of those shortages happening. While both the FDA and ASHP list at the time, I haven't looked today, did not list buprenorphine sublingual tablets as currently in shortage, the board was aware of many local pharmacies that were unable to obtain the product from their wholesalers. In response to that work group's suggestions, agency staff had added paren 3. If the drug outlet is unable to obtain the approved drug from a wholesale distributor drug outlet, documentation of a good faith effort must be retained by the drug outlet. So the work group supported this language overall, but I am going to pull out, pulled up the comments. So I have to look at it real quick. One member said no issues. One member said they liked paren 3. They liked the documentation of the good faith effort. Makes them think that separate documentation is needed, or do they just need to keep the invoices? One work group member did not want the rule, but did like the changes that were made, but wanted to fix the documentation language. One did not provide comment. One liked it. So it's kind of a mixed bag. There's no overwhelming majority here, but paren 3 seemed to be received relatively well to make that middle ground of, we get that their federal lists aren't always updated, and sometimes you just can't get products that are on the aren't on the federal list. So while the work group, contemplated this language, agency staff have some concern that by being more permissive than FDA guidance, it could potentially put outlets in a situation where our rules permit something that the FDA would say is not compliant, should the outlet be inspected by the FDA. Nevertheless, we felt it was important for the board to have this discussion in public and determine if the rule should go to rulemaking or if it should be removed. And so we would like board member direction if they would like to include a rule about this in the package for patient safety, or if you would like to not because of the potential to conflict with the FDA guidance. Back to you, Board President Doyle.
Member Doyle, thank you. Staff Member Davis. So I'm opening up a conversation about 855-183-0170, specifically also addressing whether or not board member is interested in carrying through Area 3 to rulemaking, which offers greater permissibility. We begin conversation with board member Joyce.
Okay, board member Joyce, I mean, the intent, of putting this here and, intent, believe is good, but, I'm waiting to hear what others think. There's a drug shortage and then, you're documenting what you did to try to obtain the drug. Need to force outlets to document it. I'm kind of on the fence with that. I know patient safety wise, you want to see that the outlet is making the effort to obtain the drug. But I'll pass for now.
Member Patel.
Board Member Patel, yeah, I was part of this work group and I give the comments and I agree that FDA or all the shortage list is not accurate. They have like really long lag phase. And yeah, if they say they're shortage or not shortage, it doesn't mean you can get it from your primary wholesaler, right? So that's another thing, that your primary wholesaler is different. Let's say there's only 3 primary wholesaler, McKesson, Cardinal, and ABC. So ABC might have it, but then Cardinal, they don't have it. So that's another thing. So I like that pharmacist, compounding pharmacist. And then there is another issue. If it's a shortage, like it's going to be pretty expensive. Do you really want to pass on that expense to patient, right? I mean, if it's on shortage, usually the drug price go really high. So with that said, I would like that compounding pharmacists, they have ability to make their judgment and then do the good faith effort that to get the medication, but if it's not, then they can do compound. And then I don't really big fan of the documentation. Trust your pharmacist. You should, and we should. Thank you.
Member Evans.
It's not at this time.
Member DeBarmore.
Board member DeBarmore. I think that, I think this language needs to be a little bit more clear that it's not a requirement of all 3. In order for a pharmacy to compound a copy of an approved drug, it doesn't say or anywhere in there. So it potentially could look like that it needs to be all of them in order to meet that criteria. So just adding that. I'm not, should 3 be small c instead of its own? Because right now it looks like it needs to be 2 and 3. It's to be on the shortage list and you can't get it, is what it looks like.
Yeah, I think
When I
the
read it.
stuff we're doing, because I think the first sentence in 3 might need to be C. And then I'm not sure if the second sentence would stay at C or if it would be its own number, but we can make a note and when we come back.
Okay.
Make sure that's clarified.
And saying the drug outlet is unable to obtain it from a wholesale. Want to make sure it's clear that it's wholesale they're contracted with, and we would not be expecting them to go contract with alternate wholesalers that may have it. To your point,
Yeah.
That's not an easy process, and it doesn't make sense. So just to make sure the words are clear that it would not be intended that every wholesaler is out. And then lastly, the documentation. Perhaps instead of documenting the good faith effort, is just maintain evidence. Wholesaler not have it or something. Adding documentation to me implies that someone has to write something down. I called so-and-so, or I did this. And name, initial, date, blah, blah, blah. But if you get a whole, you get your invoice and it says 0, 0, 0, 0, it would be maintaining that documentation and not needing additional documentation. So that makes sense. But I am in favor of having language because it is, I think it is a question that will be asked very regularly if we don't have language. Just cleaned up just a little bit.
Member Hall?
Member Hall, yeah, I agree with the the part about documentation, just makes me think, you know, for documentation and we have to write down if we called and so I think just seeing that you can't get it from your wholesaler. Make that a little more clear. Fine with everything else.
Member Beeman?
Member Beeman, I'm not in favor of this rule as a whole. I don't find it wise to base our rules on guidance documents of other entities. Especially when we ourselves hold our guidance documents in recent years. And so it is, just don't think I am not for that. And I know at least one of the other, or I'm trying to remember, at least one of the other work group members expressed comments to the same extent. And I think that to be dependent on these shortage databases and shortage lists, you're behind the curve. I think that a barrier to patient access, especially to continue therapies that they may have been on for a period of time. I understand that 3 carves that out to make that faster. But I just, I don't think we need to have this. Don't think we need to be more restrictive. The guidance document is there for people who choose to compound to review and to incorporate that with their USP and changes, whatever stage they're at, adaptations. But I don't think that we should be implementing rules based on the guidance, and not based on other rules that have gone through review. Thank you.
Member Doyle, I support the rules as drafted before us, and also agreeing with the comments that Board Member DeBarmore had stated already. Member Chin?
Board Member Chen, at this stage, I'm in support of the changes that Board Member DeMarmor also suggested, with B having an or 3 becoming C, with the documentation having a different. I don't like this good faith effort. I think that having documentation that you couldn't get it or whatever you already have should suffice, but however you want to word that.
Member Joyce, I understood you to have somewhat of a come back to me statement before.
Yeah, I mean, it's been kind of clarified, just. Yes, there should be proof, but having specifically, proof of good faith effort, a separate proof is too much proof. As long as there's, you know, as mentioned, some kind of information stream leading to the fact that you try to get this product. Just cleaning up of the language, I guess, but no separate documentation of good faith effort. Or just have it, basically, right? It's kind of what. Yeah. Board Member Hemmons, you asked to come back to.
Nothing to add.
Board Member Patel.
Board Member Patel, so a question for Board Member Beeman. So you're saying like you don't like the whole section of 855-183-010?
Board Member Beaman, yes.
Okay, actually, I'm also in the same thinking, but I thought we only going to talk about number 3. That's what I just make comment, but I'm with you. I totally agree. We don't need that section. And because sometimes I agree, like the patient, even though the commercial version available, and if you do the compounded version because of shortage, now get that used to with it because there is inactive ingredients is different. And so if you're allergic or not like some inactive ingredients in the commercially available product, but now because of shortage, you make the compound and due to the different inactive ingredients, they may be more tolerated or anything. So if that's the case, then yeah, I'm also in a favor of like, we shouldn't have this the whole section. And I agree. I remember it's just the guidance document and we should not make the rules based on the guidance document. So thank you.
Member Chen.
Member Chin just had a thought process of listening to look at the FDA shortages and the American Society of Health System pharmacies that they're not typically up to date at all. The real crux is for me, whether you can get it from your contracted sale distributor and not really what a list says is whether or not you can get it. And it just cut to the chase to be, you can't get it, that's the shortage. I'm just asking people who look at this stuff, because I'm hearing several people say these are not usually accurate. And we're behind the curve and it does, so why were we looking there rather than if I can't get it, that's the shortage?
For Beaman, my fear is, when this comes down to enforcement with the language that's here, even if it is just number 3, what are we holding our licensees accountable to? I think it's, the good faith effort can be interpreted broadly. Because like I hear talk of, oh, well, we tried to order and it said 0. That takes a day to that feedback potentially to get that invoice for your proof of good faith effort. If that patient doesn't have that day, can't just check a website and say whether it's in stock or not. We can't. So I worry about like just hearing the discussion here. In addition to my concerns about basing it on a guidance document, that good faith effort is so broad and the way our rules are heading and being so prescriptive of things, that good faith effort is, my experience, inherent in part of compounding. So you're not wanting to make copies necessarily. But it's also, you have to take into consideration when discussing compounding. It's, so you take that day to order it, to get your proof, to retain, for how long, for what, for where, and then that day that you can't, you may or may not still have to use another day or 2 to order in your active chemical to even be able to start the compounding process. That may take, I don't know how long, it depends on the dosage, but it's not as instant as we're going to order it in and have it here for you tomorrow. So the more burden of proof that we're mandating outside of what a pharmacist deems as in their professional judgment, in their practice, is adequate documentation. Or delaying things by, I think, a lot more than what is perceived to but what is perceived by people who in theory conceptualize a standard pharmacy setup. And the hard thing is with patient access is they don't often have a huge supply left by the time they realize that their primary pharmacy is not going to get in the drug that they're taking. And so they're already in a lot of cases on a time crunch. And then that time crunch is being used up by the necessary delays that a specified route of documentation and specified would cause. And then also, how is this going to be perceived by a board 2 years from now, a board for 3 years from now, board staff in the future as what's good faith, what's enough. So if by making it, I just think it's already inherent in compounding that you're not making what's commercially available on the forefront, that this is, it's too prescriptive, it's too much, just too many boxes to check, as I'm always saying, too many boxes to check.
Member Shin?
Last comment is appreciate everything that you just explained. I look at people on the board who are doing the, the work. We're looking at high level, highly innocent of rules and right and wrong and ethics, because we wouldn't be here if we weren't. What do you write? Where do you put in rules to prevent bad actors? And to prevent, because I think, part of the whole FDA thing was because there are bad actors who are doing compounding of things that are been harmful to patients. So we're not trying to write rules for the best of the best. We're trying to write rule to protect the public from people who aren't those actors. So how do we how do we get that there?
Bertoni?
So AAG Bertoni, I've just been listening, and I was going to suggest some language options for the board to consider, just based on what I'm hearing in the discussion, if that's not online. On line 1327, the good faith effort, you could replace that with something like documentation of attempt to obtain the drug must be maintained. So then we don't have this sort of squishiness of what does a good faith effort mean? How do you, as a highly conscientious person, experiences that versus another practitioner who's maybe less conscientious? And what kind of burden does that impose on people in their practice? So that was the thought. I also heard some discussion about should this 3 be or following 2A and B. It's a little hard because you can't see the whole thing at once. But I think if we could just scroll back up to record for 1, yeah. So if at 1310, it said they only compound blah blah blah. If one of the following apply, then you'd have 1. It's changed to produce, 2, it's on this list, or 3, you can't get it. That would solve the or question, I think. I just wanted to offer those 2 suggestions about drafting if they're of use to the board.
Member Doyle, thank you. I'm going to call time for now. Lunch, it's 12:08. We're going to be taking an hour lunch. We will have an opportunity to mull this over, and also Council Bertoni's suggestion will resume at 1:08. The public is asked to please vacate the room so that we may secure the environment, and at 1:08 we'll resume conversation on this topic. Thank you.